Crohn's disease. So pretend that you're a doctor, right? And this patient comes in, they give you all of these chief complaints, all these symptoms, and you take their full history, but you think, based on all this information, that this person must have Crohn's disease. But of course, you cannot diagnose them right there, right then, right? You need evidence. You need to do lab tests. You need to do imaging, right? This whole process. So, what would the steps be in diagnosing this patient who has Crohn's disease? So we know in medicine that you don't want to go to the specifics, right? You don't want to go directly to the disease that you think it is, right? You want to start from broad and then work your way specific to eliminate all of the diseases that are not involved. So a good way to start is by testing for malabsorption because Crohn's disease is an inflammatory bowel disease, right? So it's going to affect the intestines, the GI tract. Now, when the GI tract gets affected, there may be some malabsorption. So one good way to start off is by taking a comprehensive metabolic panel, a CMP. When you take this, you might see that the patient has low protein because their GI tract isn't absorbing amino acids so well anymore, so their liver doesn't have enough materials to make protein. Now also, because this patient may be cachectic or very skinny, because they're not absorbing all their nutrients well, they may have an increased creatinine, which basically happens when you start breaking down your own muscle for energy. Now next, we can do a CBC, right? We know that very important things in making red blood cells are vitamin B12 and iron. When you can't absorb these properly due to a problem with your GI tract, such as in Crohn's disease, you may not be able to make enough red blood cells. And in fact, you may also make improper red blood cells. So not only do you not make enough, but you also make improper ones, such as macrocytic or microcytic anemia. So having very big red blood cells or very small red blood cells. So this you'll also be able to see. And then thirdly, we have this stool sample. This one is super, super interesting. So not only is, the first thing is, this patient, one of their complaints may be diarrhea, right? We know Crohn's disease can present with diarrhea, but so can many other diseases. So you don't want to just think, okay, it's got to be Crohn's disease. So you want to eliminate all other causes of diarrhea, which can be infectious causes, right? You can have infections that cause diarrhea. So you want to test for kind of all the kind of microbes or pathogens that could potentially cause infection, right? So that's one reason why stool sample is super important. Now, the other one is because during during Crohn's disease, there's a lot of inflammation going on, right? And we know during inflammation, your liver will make a lot of proteins like CRP, right? C-reactive protein, right? Which is an indication of inflammation, but it's not an indication of specific GI inflammation. It's just general inflammation. So these two proteins here, that are fecal calprotectin and fecal lactoferrin, that are made by neutrophils, these are unique in GI inflammation. They are made by neutrophils during inflammation specific to the GI. So that's pretty important because this can tell us that this inflammation that's happening is localized to the GI tract. Now, we know that sometimes lymphocytes can get involved, right? And lymphocytes make antibodies. Now, we know inflammatory bowel disease has two types, right? Crohn's disease that we're talking about now, and ulcerative colitis. Now, during ulcerative colitis, the lymphocytes can get activated to make these antibodies called P antibodies, which are basically anti-neutrophilic cytoplasmic antibodies, so antibodies against these neutrophils. But this doesn't happen in Crohn's disease, only ulcerative colitis. So this is one pretty good way to make sure that Crohn's disease is the cause and not ulcerative colitis. You can also do this ASCA one, but this one is literature has shown that ASCA is not that sensitive, so it's not such a great test to do. ANCA is though. So these are very good tests to just show that there's malabsorption going on. It doesn't show that it's Crohn's disease or anything like that. It just shows that there's malabsorption going on. But we want to prove that this malabsorption is due to Crohn's disease. How do we do that? We need to do some imaging. We got to do the gold standard. That just means the best possible test, which is ileocolonoscopy and biopsy. What does this mean? This means you take a camera, you put it up the anus, and you go explore the GI tract, right? Now, what kind of things are we going to look for that's going to tell us this is Crohn's disease and not some sort of other disease? Well, the key things that shows us it's Crohn's disease is this. We know that Crohn's disease is an inflammatory disease of the whole GI tract. It can happen anywhere, from your mouth till your anus, right? So it can happen anywhere. But some key lesions that we got to look for are these, okay? There are many other ones, but these are the ones that are quite unique to Crohn's disease. So let's look at this one, skip lesions. So if we look at any region of the GI tract, we may see this. We may see that there is damage in some places, followed by normal places, followed by damage, followed by normal. So this is called skip lesions, because this is unique to Crohn's disease, because in ulcerative colitis, there will be continuous inflammation. There will be no healthy tissues in between the damaged tissues. So that's unique. Also, cobblestoning. Cobblestoning is this little pattern here that I showed. This is basically when there's inflammation causing an outpouching, and surrounding that inflammation, there's ulceration causing indenting. So this forms this like cobblestone-like appearance, this granular-like appearance, right? And also, the inflammation makes this wall very thick, right? Very thick, you can see. Because this is a normal wall here, but this is very thick. This inflammation makes the wall so thick, causing something called strictures, which is like basically obstruction, because some things can't pass through anymore because of the thinning of the wall, so there's not enough space for food, so it kind of causes an obstruction, a blockage somewhere as well. Now, this one is also important, fistula. This is basically when an ulcer goes so deep that it starts penetrating out of the intestine. In fact, this pipe will go and lead somewhere else. So instead of only having food exit out of your anus, it may in fact start exiting out of random places and lead to your skin. It can even grow, this pipe, and go to your skin. So you can literally poop out of your skin. Or it can go to a bladder, so you can literally poop through your pee. Like it's actually insane. So these fistulas are quite interesting and unique to Crohn's disease. Now, some other ones include abscesses, strictures, and ulcers. But these are not super unique to Crohn's disease, maybe just the abscesses, because these fistulas that start forming can start having an infection going on, and that causes an abscess, which looks kind of like this. Okay, now while you're there, you want to basically take a biopsy, right? Because you're in there, so why not take a biopsy? So when you take a biopsy, what's the purpose of this? The purpose of taking a biopsy is so that you can look at a microscopic level what's going on. So let's put it here on a microscope and we're going to look what's really going on. With Crohn's disease, there are two key things that you can find by a microscope. One, transmural inflammation. The inflammation goes through all 4 layers of the GI tract, right? The GI tract has these 4 layers, mucosa, submucosa, muscles, and serosa or adventitia, right? Now, it can penetrate all through this, whereas ulcerative colitis, or UC, doesn't penetrate all layers. Now also, we can have some granulomas like this. It's basically a collection of all these macrophages, lymphocytes, encapsulated inside a fibrous little ball, right? And this is you call this non-caseating granuloma because there's no necrosis going on. And we can see this in Crohn's disease, right? Instead of ulcerative colitis. Now, based off of all of these, right? Your lab test, your imaging, your microscopic examination, based on if you get these signs positive, you're very confident that this person has Crohn's disease. We don't know the reason, we don't know anything like that, right? That's for another video, but you know that this person has Crohn's disease. And now you got to bring them the news. So you tell them this bad news, right? Now, what happens next is for another video. That would normally be finding the cause and then doing the treatment, right? So, but that's it for this video. I hope these diagnoses make sense on how it works and what you got to do.